Good morning. Yeah, we seek your indulgence. We are sorry for this late presentation. My name is Dr. Kariuki Michael. I'm a pediatrician and founder of the society with my colleague, Dr. Okanga, who is a physician gastroenterologist. We are just here briefly to present on harm reduction on alcohol, pesticides, and tobacco. Next. So this is what we do: advocacy, awareness, campaigns, capacity building in the areas of alcohol, tobacco, pesticides, and cannabis. Next. We also do research and a lot of tobacco harm reduction. Next. That's our mission and vision, and essentially we want to mitigate harm in the society in those 4 fields. Our objectives are many. Next. Our objectives are many, but our approach is evidence-based harm reduction approaches, what we call implementation science. With the tobacco, next, smoking cigarettes or other combustible tobacco products is the biggest cause of preventable NCDs and deaths occurring in the world. And of course, 8 million people die of tobacco consumption yearly. Next. Our statistics as at 2022, we were 13% prevalence, 11% in 2023. About 1 in 10 Kenyans aged between 18 to 69 use tobacco. And the age initiation as per NACADA is 6 years. Next. Tobacco is the only product, if used correctly, as intended, will kill you. And actually 50% of tobacco users die. 1 in every 2 people. Next. So what is harm reduction? It's also called harm minimization, a range of intentional pragmatic practices and public health policies designed to lessen the negative social and physical consequences. Those are examples of harm reduction: seatbelt, sunscreen, condoms, next, helmets, masks, designated driver, of course, sterile syringes, speed limits, methadone clinics. We are very much aware of this. Next. WHO's Framework Convention of Tobacco Control has defined what it is, and harm reduction strategies is part of that definition. The only issue is we differ on what strategies to apply for harm reduction in tobacco. Next, these are the Empower tobacco control measures as defined by WHO. We call it Empower. And what we do implement all this as a country, except the third one, where Stop Smoking Services Department, we don't have one. We leave smokers to their own peril. We tell them to quit the cold turkey way, and therapies that are available are not affordable to them. Next. Tobacco addiction is real, has both physiological and behavioral components, and both must be dealt with. Next. As a society, we are calling for affordable nicotine replacement therapies. These things are not affordable to most smokers. Next. There is a lot of traditional smokeless tobacco use in this country. We don't know what these products contain, and there are quite many. Kuberi is one of them, and there is a lot of adulteration in these products. Next. What are others doing? The United Kingdom passed a project called Swap to Stop. It may seem controversial, but it's real. But they are targeting 1 million smokers to swap their cigarettes with a medical vape. It is there, you can read about it. Swap to Stop is a campaign that UK is implementing. And their vapes or e-cigarettes are graduated and issued through their Stop Smoking Services Department and the NHS. Next. World Medical Organization's statement is very critical because we must protect our children. That is very critical, adolescents and young children, especially through packaging of these products. There is absolutely no regulation in sale and distribution of these novel products. Next. For the Kenyan context, a motion was introduced in Senate. The approach was wrong because this motion should have been introduced in Parliament. And the whole idea is to try and regulate these novel products that are coming up because we have no regulation. Next, so we are calling upon the use of implementation science, evidence-based practices and research by practitioners and policymakers to combat the tobacco menace, affordable, safer alternatives, promote access to knowledge, and avail affordable NRTs. Next. For alcohol, we have quite a number of harm reduction strategies, moderation strategies, eat and drink water, nurse drinks, taking small sips, no binge drinking, and of course, measure and count your drinks. It is recommended that you should have 2 standard drinks, which is 350 ml of beer, which is about 5%, or 150 ml of wine, which is about 12%, or 45 ml of hard alcohol, which is about 40%. That's the recommendation. You should not have more than 4 drinks at a single sitting and not more than 10 in a week. For women, the quantity is low. You should have at least 1 standard drink as per the recommendation per single sitting. Of course, we have medications that are used. We should avoid mixing substances, drink less alcohol content, arrange safe transportation, abstinence days, understanding alcohol poisoning. It's important to know what does it entail. And for breastfeeding mothers who partake alcohol, there is a recommendation that they need to use breast milk test strips before they breastfeed. So as per the color change, it will guide them on the alcohol content of that breast milk. And of course, do not or limit alcohol at home. In as far as alcohol is concerned, it's important to know when is it time to get help. You cannot force somebody into getting help. So we must recognize and understand the problem. And of course, very important to understand the addiction. Next. We must find appropriate treatment. Next. 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 We must find appropriate treatment because there is no one-size-fits-all approach. It must be individualized. Next. For parents, we must understand what our children are taking and what are the reasons for using those substances and what are the ways to improve communication and to reward non-using behavior while discouraging substance abuse or use. And of course, recovery resource centers, we must actively listen. We must limit the setting and consequences, understand why are they using these products. We must have what we call positive reinforcement and manage fears and anxiety. Managing recovery, very critical, because this is now where the rehab comes in. But what we have been lacking is post-rehab safe houses to transition these people so that they don't get back into relapse. Those are the way forward for alcohol. Implementation science is very key. Seamless care for purposes of continuum of care. Establish adequate safe houses, which we don't have. Ensure access and affordability of care. And of course, repatriation of those abandoned patients. Then we come to the aspect of toxic business, which I know quite a number of pharmacies engage in. Next. Next. So the toxic business, this is about pesticides. We have a lot of pesticides in this country that are highly hazardous, which is defined as an LD50 next, as an LD50 orally of 5 to 50 or DAM of 5 to 200. So we have so many of these products in our Kenyan market, and we are calling upon the Pesticide Control Board to do something about this. There is a lot of friction between Ministry of Health and Ministry of Agriculture. Ministry of Agriculture is looking at food security. Ministry of Health is looking at the health of the people. but we must come to a common understanding that these pesticides are harmful. Next. If we fail to provide assistance, then these products will kill and will continue killing our population. Also very important to know, only 5% of pesticides produced globally are used in Africa. Only 5%. We are not serious farmers. That is what this is trying to say. But that 5% is causing a lot of havoc. Next, and the havoc that it's causing, next, is endocrine disruption. Especially in pediatric cases, we have a lot of endocrine disruption that we are seeing, carcinogenic, reproductive and development toxicity, mutagenicity, neurotoxicity. In Kenya, we have about 68 tons of pesticides, of which 52% are pesticides for plants, 27% are fungicides, 21% are insecticides. Next. Only 2% are biopesticides, and 76% are highly hazardous in the Kenyan market. And only 22%, as defined by LD50, are non-highly hazardous pesticides. The next slide shows the ban of pesticides in European Union, but we are using 44% of pesticides that have been banned in the European Union. So that tells you a lot that we must take care of our interests. Because if these products have been banned elsewhere, why are they being sold here to us? There are quite a number of pesticides. I won't go through all of them. Can go through the next slide. The next. These are the top 30 products in Kenya according to volume of application. These are the top 30 products with the biggest, highest sales value, and they're out there in our agrovets. These are a summary of the bioproducts available in Kenya, but very costly. So one of our clarion calls is to make these biopesticides affordable, as we call for elimination of the highly hazardous pesticides. Next, this one shows the proportion of plants. You can see maize is the leading. So maize is a staple food, and it is the most sprayed, followed by wheat, followed by coffee, potatoes, tomatoes. So these are regular products that we are using on a daily basis. And the component, next, almost over, the component of highly hazardous pesticides used in our maize plantation is almost 80%. Next, we all know this glyphosate controversy. The Ministry of Health submitted an official recommendation to remove this. We have several examples in the market of pesticides that contain glyphosate, and we need more research. And the fight between Ministry of Health and Ministry of Agriculture must come to an agreement that the health of the people is important. Mancozeb is a fungicide, and we are calling for the ban of that product. Next. This is a study that was done in Kirinyaga County, and essentially it shows, it elucidated the acephate. Acephate is a very strong endocrine disruptor. It's highly used in Kirinyaga County. Next, this is a study that was done in Kenyatta that shows that about 43% of poisoning cases arise from pesticides. How do we mitigate the risks? Next. We must create buffer zones. Unlike Europe, where they have winters and the other climatic changes, here we don't have, and neither do we have buffer zones in this country. So you'll have pesticides being used all the way to Turkana, no buffer zones. That is a key strategy. We must educate the users, we must use PPEs, appropriate labeling, especially for those who don't know how to read and write. Pre-harvest time. Yeah. That's the last one. Pre-harvest time. You spray your miraa today, you harvest in the evening. You spray your skumas today, you harvest tomorrow. That has to be checked on, and of course, regulation. These are the same recommendations on phasing out highly hazardous pesticides. We need to implement an integrated pest management strategy, promote access to knowledge, invest in research on biopesticides, ensure affordability, and address corporate responsibility. That's the last slide. Thank you very much.
Happy,